Hello students. Now today's session is yet a very interesting session. It is the time for the INI-CET recall session and the exam having been done yesterday. Today let's see what questions were there and how to analyze and go further and prepare better. So with this, let's have a short overview. Now in this year's INI-CET, we had 14 questions from pediatrics and the high yield topics what I found, which means where more than one question, two questions were the maximum from each topic. So they were from genetics, cardiology and metabolic conditions in pediatrics. The most of the questions were primarily problem solving questions, which is what your entire curriculum is about. That is about the competency based curriculum. Right from the beginning, you're training towards problem solving. So this also was exactly like that. Must be very simple for you all to understand that problem solving is how you're going to be having critical and analytical thinking. So that was what was tested. Difficulty level when I felt it was moderate and almost as similar as the previous exams. I didn't find this exam too difficult actually. So I'm sure all of you who are prepared well, this should not be a problem at all. So with this short introduction, let's begin. The first question, a term neonate presents with respiratory distress. The chest x-ray shows hyperinflation with prominent bulging of the middle fissure. Now, this baby got well after 2 hours. What is the likely diagnosis? Now, for all of you, I want you to have common sense. Just by common sense thinking, this was a baby, term baby, so that rules out all your respiratory distress syndrome of prematurity and all those causes, hyaline membrane disease. If they even come in the options, they are ruled out. So, what is left are the conditions of a term baby. They are transient tachypnea of newborn, RDS in term babies, congenital pneumonia, and meconium aspiration syndrome as the choices are. Now here, what have they discussed further? They have done an X-ray and found that the X-ray showed prominent bulging of the middle fissure. Now this essentially, when does the middle fissure show bulging? Now the middle fissure shows bulging when there's little bit of lung fluid. So this lung fluid which comes in the middle, that shows a little bit of widened middle fissure in the X-ray. Now what happened to this baby? This baby got well with hardly any intervention or maybe minimal intervention. The baby has gotten better. Now a baby which got better with minimal intervention, which means as the baby cried vigorously, this lung fluid got absorbed and baby became well. So automatically what will be the diagnosis? This is a transient condition. So when we have a transient condition, what is your diagnosis? The diagnosis is A, transient tachypnea of newborn. So now let's just have a peep at the others. You have respiratory distress syndrome. Now this is typically described only in preterms because of hyaline membrane disease. But we do have a component where even a term baby can have respiratory distress syndrome because of multiple causes. They can be congenital causes, congenital surfactant deficiency, so many things can be there. Now none of these causes will be where there is only bulging of the fissure and the baby getting well in 2 hours. So automatically those causes get out. Similarly, congenital pneumonia. All of you know, congenital pneumonia occurs because of intrauterine infections or infections which ascend from the vaginal tract into the chorioamnion and the amniotic fluid. These children have aspirated the infected amniotic contents, and because of the aspiration, there is pneumonia. The pneumonia will not vanish in 2 hours. Congenital pneumonia takes time. And one other important thing, congenital pneumonia even takes time to evolve. The children may not have respiratory distress starting at birth. So, it will not disappear in 2 hours. You will have X-ray features showing bilateral infiltrates, lobar pneumonias, typical features of pneumonia / bronchopneumonia in the X-ray, not only prominence of the fissure. And the child is not going to recover in 2 hours. So that rules out congenital pneumonia also. Meconium aspiration syndrome. Now, meconium aspiration is a very strange condition because meconium by itself is a sterile substance. And when the baby is hypoxic or experiences some distress or acidosis inside the uterus, the baby's anal sphincter tends to relax, and that causes the meconium to be passed out. This meconium comes in the amniotic fluid and the baby aspirates the amniotic fluid. Now, when the baby aspirates like that, what happens? This sterile meconium, but it is granular, it is particulate. This particulate sterile meconium enters into the airway, goes into the bronchus and the bronchioli and obstructs various small airways which are there. Automatically, such babies, unless it's very severe meconium aspiration, they may not develop respiratory distress immediately at birth. The larger airways and many of the airways where the meconium did not go and get blocked, they tend to maintain the homeostatic mechanism and child's respiratory distress is not evident initially. In meconium aspiration, slowly over a period of time, and this time is anywhere between 2 to 6 hours, the meconium which gets obstructed in the airways incites a chemical pneumonitis change. This chemical pneumonitis tends to cause fluid and inflammatory changes into the airway, and then the respiratory distress tends to worsen. So what I'm trying to tell is that meconium aspiration syndrome, if the child is presenting with very severe meconium, they will start presenting respiratory distress at birth. But this will only worsen as the child grows older into day 1. Some meconium can present even up to as late as 6 hours of life, but once the first 6 hours are crossed, very rarely will meconium aspiration syndrome present. So you should learn from each MCQ multiple things. Like from this, it is very evident. Baby got well in 2 hours. Anybody will take transient tachypnea. But suppose the question was, formulated a little differently. Where the question said that the X-ray did not show any great findings. However, baby started worsening after 2 hours and required intubation at 6 hours. Then what could be the diagnosis? Then your diagnosis can be between congenital pneumonia and meconium aspiration syndrome. That is how you're going to evolve the diagnosis, where based upon how the child's improvement is, the diagnosis will change. Transient tachypnea, rapid recovery. Congenital pneumonia will present at birth and slowly keep on deteriorating. Meconium may be fully fine at birth and then start deteriorating and then will require support or whatever oxygen therapy. So that is why in this case, the diagnosis transient tachypnea of newborn. Coming to the next question. Now this is a question on growth and development. A very important chapter, the growth and the anthropometry. A 7-year-old child with stunting is brought for evaluation of short stature. His height is below 2 standard deviations for age. The developmental milestones are normal. On examination, the upper segment to lower segment ratio is 1.4. When they say 1.4, it means 1.4 is to 1. Upper segment is 1.4 and lower segment is 1. What is the following? Which of the following is the most likely diagnosis? A. Achondroplasia. B. Spondyloepiphyseal dysplasia. C. Nutritional causes. And D. Growth hormone deficiency. Now, very clearly, this is from your chapter of anthropometry and short stature. Now, when upper segment, lower segment ratio was taught, it was taught to you that there are two types of short stature, disproportionate and proportionate. Proportionate short stature means the upper segment, lower segment ratio, as is supposed to be for age, that is maintained. That is proportionate short stature. Then what is the upper segment, lower segment ratio for age? Now at birth it is 1.7 is to 1. An easy way to remember it is at 3 years it is 1.5 is to 1. At 5 years it is 1.3 is to 1. At 7 years it is 1 is to 1, and above 7 years it usually remains 1 is to 1, or it can come down to 0.9 is to 1. So remember, at 3 years, at birth 1.7 is to 1. At 3 years, 1.5 is to 1. At 5 years, 1.3 is to 1. And at 7 years, 1 is to 1. It goes opposite direction, the way the table what we are discussing, upper segment, lower segment ratio. Now, this is a 7-year-old child. Now, what did I tell you? At 7 years, the upper segment, lower segment ratio should be 1 is to 1. Here it is 1.4 is to 1. When you say it's 1.4 is to 1, The upper segment is 1.4 and lower segment is 1. That means the short stature is no longer proportionate. This has become disproportionate short stature. Automatically look at the causes. You have nutritional cause, you have growth hormone deficiency. These two are causes of proportionate short stature. So automatically nutritional cause C and cause D, the growth hormone deficiency, get ruled out because 1.4 is to 1 automatically implies disproportionate short stature at 7 years. So what are the two causes we are left with? We are left with achondroplasia and spondyloepiphyseal dysplasia. Now achondroplasia is what? Achondroplasia is also called short limb dwarfism. And what is spondyloepiphyseal dysplasia? Spondyloepiphyseal dysplasia is spondylo. This word is used for the vertebra. So among these two, in one, the upper segment is small, in one, the lower segment is small. Now, in the child, you're deciding the upper segment lower segment ratio shows that the upper segment is bigger than the lower segment, which means the body is growing, the limbs are not growing. That means there the vertebrae are normal, limbs are not growing. So the answer is automatically achondroplasia. Because in spondyloepiphyseal dysplasia, the upper segment lower segment ratio will be reversed. It will be 1:1.4 or something like that. So there the vertebrae don't grow. So the body is short and the limbs are normal. So the ratio will be altered. The lower segment will be bigger than the upper segment. So in this, the answer will automatically be achondroplasia. You all understood? In achondroplasia, you have short-limbed dwarfism. So here, the limbs don't grow, but the body is growing. So since the body is growing, the upper segment is normal. So as a ratio, the upper segment and the lower segment didn't grow, remained small. So the ratio, the upper segment looks bigger as 1.4:1. So I hope you all understood that. Let's go next question. Which of the following is or are seen in Hirschsprung's disease? Now, A is failure of migration of the ganglion cells. They have not written ABCD, but it's ABCD. So one is failure of migration of ganglion cells. Two is where the intestinal obstruction is caused postnatally. Three is where the distal segment is dilated. Four is the proximal segment is constricted. Now, Hirschsprung's disease is a condition where there is congenital colonic aganglionosis. No nerve cells are there in either whole or part of the colon, and this colon terminates just before the anal canal. So till there is no ganglion. It's aganglionic. Now, what happens here? Now, here, when there are no ganglions, the myenteric plexus and the Meissner's plexus, these two plexuses do not function. So, what happens? Normally, the peristalsis should happen from top to down. The squeezing, relaxing of the intestinal content should be happening. That cannot happen. So in Hirschsprung's disease, in a short segment, intermediate segment, long segment, there are multiple areas where in a short segment, only for a small segment, there is no ganglion. In intermediate segment of colon, there is a long area where it is not there, but still there is a good enough intestine where the ganglions are present. And in whole colonic ganglionosis, there is no ganglion anywhere in the colon. Colonic peristalsis does not happen. So what happens? The meconium or the breast feed or whatever feed the baby is on, that reaches slowly from peristalsis from the esophagus down to stomach, duodenum and small intestine. It reaches the colon. So when it reaches the colon, what happens? It keeps on accumulating at one point. Beyond that point, there is no neural plexus for relaxation and constriction. So at that point where there is no nerve plexus, above that is called the proximal segment. Below that it is called the distal segment. So by sheer logic and common sense, if something is going down and down each time and there is no peristalsis occurring in the distal segment, How will the distal segment be? The distal segment will be flattened or much constricted because it's not able to have any peristalsis. There is no colonic material to go down. What will happen to the proximal segment? It is going on receiving more and more of the colonic material from the small intestine. So it keeps on becoming more and more dilated. Sorry, it becomes more and more dilated. This dilated colon is seen in the proximal segment. It goes on receiving more and more. The distal, in between, you have the aganglionic segment, and the distal part, you have the distal segment, which is totally collapsed. So, what is written here? Distal segment dilated. How can the distal segment dilate? It has no material inside it. It cannot relax. The distal segment is not dilated. Proximal segment constricted. That is wrong. The proximal segment actually receives more and more of the food material and the colonic material. So it becomes more and more dilated. So it is vice versa. Proximal segment should be dilated. Distal should be constricted. So C is the third option and the fourth option are wrong. The first option, yes. Hirschsprung is the failure of migration of ganglion cells to form the measles and the myenteric plexus. Correct. Two, it causes intestinal obstruction postnatally. Absolutely right. It does cause intestinal obstruction postnatally. So the correct answers are 1 and 2. 3 and 4 are wrong. So among A, B, C, D, which shows the correct 1 and 2 options? It's option C. So the correct answer is C. Next question. A boy is brought for evaluation. He has stunting with excessive weight gain. His height is below second standard deviation for age and weight is above the second standard deviation for age. So height below -2 standard deviation. So he's stunted, whereas weight is above +2, so he's obese. Developmental milestones are normal. He has a history of recurrent respiratory tract infections for which he frequently receives oral medications. What is the next best step to do? Now, let's look at this question very clearly. Here's a child who's short and obese. Now, there should be a reason why he's short and obese. His development is normal. So, automatically, development is normal. Many of these congenital syndromic children get ruled out here. Okay. Now, they have given another important part of history which says he has recurrent respiratory tract infections and he has been getting multiple oral medications for that. So we should keep that in mind when we evaluate the options. So what is the next best step to do is your question. A is promote physical activity as the child is overweight. B, screen the child for growth hormone deficiency. C, check thyroid function test, that is TFT, as the child may have congenital hypothyroidism. D, test for Cushing syndrome secondary to steroid use. Now, the next best step, always, when we have a condition, we should always try and eliminate the cause of the condition first before doing management measures. I'll give you an example. Suppose we have a patient who is, let's take an obese child itself, a child who is obese and is snacking heavily on junk food. Which is more important? Getting the child to join cycling and gym class or reducing the intake simultaneously? All of you agree that only joining a gym class and making the child exhausted but still going on eating these junk foods is not going to serve the purpose. Taking care of what is the cause is what is going to solve the purpose. Same thing here also. In this question, promoting physical activity a child is overweight is not going to be the answer. Because why he is overweight, you have to see first. So A is not the correct option here at least. B, screen the child for growth hormone deficiency. Now remember, this child is obese as well. Growth hormone deficiencies are essentially short and very tiny children. They are not obese children. So screening the child for growth hormone deficiency is also not going to be the correct answer. C, check for thyroid function test. Now thyroid function test, let me tell you one thing. In thyroid, you do have obesity. So you have a child who is short, you have a child who is obese, you also will have a child who has had recent scholastic backwardness, Child who's having cold always says it's cold, even if though it is quite warm and sunny. A child who is not interested in playing, child who has become, whose skin has become dry. These are all the conditions you will get in thyroid function test abnormalities with congenital hypothyroidism. In this child, you don't have all that. You have developmental milestones are normal, which means there is no history given regarding recent scholastic performance, and congenital hypothyroidism will have developmental delay from the beginning. So C is also wrong answer. So the last option, test for Cushing syndrome secondary to steroid use. Now, this child has received oral medications for recurrent respiratory tract infections. Now remember, one of the commonest practices here is that children who have childhood wheezing are regularly put on short course, 3-day, 5-day, 7-day course of oral steroids. Now, this is because the oral steroid works very well to open up the airways and to reduce the inflammation. So, I have seen numerous prescriptions where oral steroids are given regularly, almost on a monthly basis, many children who have recurrent respiratory tract infections. So, this child has also got recurrent oral steroids, which is why it is mentioned significantly in the history. Those oral steroids can contribute to Cushing syndrome and make the child obese. So, of all the options, option B, testing for Cushing syndrome second to steroid use, will be the best option to do next. After we stop his recurrent steroid, manage his respiratory tract infections correctly, then we can go ahead and promote physical activity and take care of the overweight nature of the child, reduce his diet, etc. can be done. So the question being, what is the next best step to do? The next best step is B, test for Cushing syndrome secondary to steroid use. Should the question have been, what all can be done in this child to improve his health? Then yes, answer A and B would have been correct. So here the option is very clear. What is the next best step to do? So the answer is D. Test for Cushing syndrome because he is most probably received multiple courses of oral steroid, because of which he is obese, and that needs to be checked for. So next question. A 1-year-old child is suspected to have glucose 6-phosphatase deficiency. Which of the following clinical features is most likely to be present in this child? Now, all of you will read the question very carefully. This is glucose 6-phosphatase, not glucose 6-phosphate dehydrogenase. Remember, clear reading of the question. Glucose 6-phosphatase. Now, where did we hear this glucose 6-phosphatase enzyme? We read it somewhere in the glucose glycogen metabolism. That is where this enzyme glucose 6-phosphatase came. Okay, GPD1 deficiency. That is what this is. So glucose phosphate dehydrogenase, glucose G6PD, glucose 6-phosphate dehydrogenase is a totally different enzyme seen in the RBC. That is a part of metabolism in the hemoglobin. Here we are talking about glucose 6-phosphatase, metabolism of glucose and glycogen. So what does glucose 6-phosphatase do? It converts the glucose 6-phosphate to glucose. So it's the last step wherein the glucose 6-phosphate gets converted to the available form glucose, which is how the cells need this glucose. So this glucose 6-phosphatase is that enzyme. Now, if glucose 6-phosphatase is removed, we are not able to produce glucose. So, what happens? You have only accumulation of glucose 6-phosphate and back inhibition. It goes into accumulation of glycogen. This glycogen gets accumulated in the liver and kidney. So, this becomes a problem where you have lots of glycogen as stores, but you are unable to utilize any of them in the form of glucose. So if you have a lot of glycogen but you cannot form into glucose, what will happen? Obviously, I'm asking. Obviously, what will happen when you can't have glucose? You will have hypoglycemia. Obviously, because the child is unable to utilize that glycogen. Now, keeping all that, now let's look at the options. Will this child have muscle cramps during exercise? Now remember, this child normally to produce glucose from glycogen itself is very difficult. Forget about exercise. Normal itself, after a period of fasting itself, where the glycogen store should be used, there only the child is having a problem, is unable to produce glucose. So muscle cramps during exercise is not an answer here. In fact, glucose 6 phosphatase children don't have muscle cramps. They find it difficult to exercise itself. Hypoketotic hyperglycemia. Now, hyperglycemia is not even there in this scenario. Hyperglycinemia, if that was given, I'm not sure if this is a text error, that there's hyperglycinemia. Now, hyperglycinemia is a condition which is seen in fatty acid oxidase defects like carnitine, sorry, carnitine metabolism pathway, carnitine palmitidyl lipidoyl transferase deficiencies, sorry. Hypoketotic hyperglycemia is a condition which is seen in fatty acid oxidation defects. Now, these fatty acid oxidation defects, here they do have hypoglycemia intermittently because they are not able to metabolize the fatty acids. Now, there you have this hypoketotic hyperglycinemia, not hyperglycemia. Okay, hyperglycinemia. That is fatty acid oxidation, not glucose 6 phosphatase deficiency. Okay. Next, so obviously this is totally different. Fatty acid oxidation defects are totally different chapter. Your glucose 6 phosphatase is glucose metabolism chapter. So B is not the answer. C, skin hyperpigmentation. No, skin hyperpigmentation is not seen in glucose metabolic defects. Fasting hypoglycemia. Now doesn't that correlate well with how we discussed this case? Yes. We did discuss that the child will not be able to produce glucose from glycogen. So after a good night's sleep, forming that glucose and maintaining the blood glucose in the fasting period, overnight fast, will become a challenge. So in a child with glucose 6 phosphatase deficiency, the child will have fasting hypoglycemia. So the correct answer is D. Next question. A karyotype of a male child shows 46XY with deletion involving chromosome 15, Q11, Q13 region. The child also has developmental delay, obesity, hypotonia, and hypogonadism. What is the likely diagnosis? Now, most of you almost this is like a spotter diagnosis. If the rest of it was not given, the fact that if I were to put a fill in the blanks, male child with deletion chromosome 15, Q11, 13 region, that is such a total diagnosis. But for those of you who have not really mugged up these, not really mugged up these chromosome and these deletions, they have got clinical features also of developmental delay, obesity, hypogonadism, and hypotonia. Typically, these are features of Prader-Willi syndrome. Now, let's look at the other options. Angelman syndrome. Now, Angelman syndrome is a totally different condition. Angelman syndrome is also a condition which affects chromosome 15, but it affects a totally different region called the UBE3A region. Angelman syndrome is a neurological condition. So, the child will have tremors. There is not essential child should have obesity or hypogonadism. Child has tremors. Child can have significant development delay. Characteristic facial features. There is no obesity. Characteristic faces are seen. So that is why just going by chromosome 15, don't take the answer. This Q11, Q13 region is what is classical in Prader-Willi. The UBE3A region is what is seen in Angelman syndrome. So the fact that they have not discussed limb abnormalities, tremors, ataxia, and the characteristic faces, this is not Angelman's. Cre-du-Chat syndrome. The Cre-du-Chat syndrome is involving a deletion of chromosome 5. This is chromosome 15. That is a totally different congenital condition. And there's a typical cry like a cat cry because of involvement of the vocal cords. Patau syndrome is a totally different condition. Here there is issues on deletion on chromosome 13. So they have selected these options very carefully just to confuse that one is 13, one is 5, one is 15, all nearby to Prader-Willi 15. But the clinical features with the chromosome should give you the diagnosis. Typical hypogonadism with developmental delay, obesity in a boy equal to Prader-Willi syndrome. So the answer A, Prader. Next question. An infant comes with 3 months of progressive jaundice, pale stools, high colored urine. The child was healthy and gaining weight, feeding well. The HIDA scan showed no excretion. What is the next step? Usually, these are infants around 3 to 4 months of age. And this child is now been doing well, however, started having deepening jaundice. Stools are pale, high colored urine. Implies obstructive jaundice. High colored urine means conjugated bilirubin is excreted. Pale stools means the bilirubin is not excreted into the bile from the bile into the intestine. So there is no formation of stercobilinogen. There's no formation of stercobilinogen. The stools look pale. When we say pale, it's essentially a like uh, pale white, when the typical clay colored stools, remember the clay is not our terracotta clay, the clay is for porcelain pot, the white porcelain china pots, they are white clay, and that clay is what is the pale stool about. So this child is not having excretion of bile into the intestine, so he is having accumulation of conjugated bilirubin in the blood, which is reflected as jaundice and is also shown as that being excreted in the urine as high colored urine. So this is a case of obstructive jaundice, which is what the HIDA scan has shown. HIDA scan showed no excretion means the dye is not excreted into the common bile duct into the intestine. There is no excretion. So what is the next step? So tell me the etiology, all of you. What will the etiology be? There is obstructive jaundice with no excretion of the bile into the intestine. So there is biliary atresia. That is the diagnosis in this child. Congenital biliary atresia. In a child with congenital biliary atresia, what will you do next? You have to know what type of biliary atresia it is. Is it intrahepatic? Is it extrahepatic? How much of the biliary radicals are salvaged? How much is not? So let's look at the options now. A. Breast milk jaundice. Stop for 2 weeks and give formula feed. Sounds ridiculous, no? We already know there's obstruction. So that's out. That option is out. Option B. Galactosemia. Do test to confirm. Now, all of you know galactosemia is a metabolic liver condition. Okay. In galactosemia, the child is unable to digest the breast milk or digest the galactose in the breast milk. Will this child who's unable to digest the only food it is given, will it be healthy and gain weight? It will never happen. So galactosemia ruled out. Okay. Galactosemic children are have very much severe failure to thrive. They have hepatitis features. They are continuously vomiting. They are sick. Okay, that is galactosemia. Starting from the neonatal period, they're very sick. The second sentence of healthy gaining weight loss never going to happen. 3. Metabolic condition requiring further testing. Now, there are conditions of neonatal hepatitis because of infections. So, intrauterine infections typically. Here also, they'll have very similar features where you have intermittent obstruction, abnormal biliary radicals, all these things. Now, in those conditions, the features of obstruction will not be there. So, there the HIDA scan will not show no excretion. HIDA scan will show some excretion, and the jaundice will be deepening, liver function will be abnormal, things like that will be there. So the fact that the HIDA scan is showing no excretion, that means there's a block. So metabolic conditions don't have block. So option C, metabolic condition requiring further testing is the wrong answer. So automatically, what did we decide we wanted to do upfront for biliary atresia? We wanted to evaluate the liver. We wanted to evaluate the biliary radicals. We wanted to see the condition of the hepatocyte. All these things before we plan what we call the Kasai procedure or portoduodenal. So that is our next option, liver biopsy. So that is the correct answer. The answer being D. Liver biopsy is the next step to plan in a child with biliary atresia. After which we can plan in the Kasai procedure of portoduodenal enterostomy. Okay, next question. A child with fever and abdominal pain has tested positive for dengue on day 5. His BP was 110/70. Platelet counts are low, 20,000 per millimeter cube. But there was no bleeding. What is the next step? Now, one thing I must discuss regarding the question. Always, BP is a function of age. Here they have not given the age, which is wrong. Or the recall has not put the age. But assume this is a 5-year-old child. Okay? 5-year-old child, BP 110/70. Platelet count low, but no bleeding. Now, 5-year child BP 110/70 is normal. So, platelet count is low, but there's no bleeding manifestations. So, when there is no bleeding manifestations and this child, ideally, there'll be next step will be only give basic base minimum fluids. Never overload fluid in dengue. Dengue is a condition which has capillary leak. You all remember that, no? Capillary leak. The capillaries become leaky and the plasma fluid exudes out. This exudes into pleural space, pericardial space, into the peritoneal space. Everywhere it can leak out and the blood can become thick. So, always give minimum fluid like 7 ml per kg per hour of ringalactate for a child who is having normal blood pressure and in dengue with fevers which is still present. So that the fever induced, the child will lose a lot of water in sweating and his BP should not start falling. So for that 7 ml per kg per hour of ringalactate will be correct. Now putting this, suppose the age of the child was given as 14 years. Even in a 14-year-old child, BP of 110/70 will be considered normal and 14-year-old children are taken like adults. Any systolic blood pressure less than 90 is when you have to worry. So even though the age of the child has not been given very clearly, you people should be able to manage this question. BP 110/70 is near normal for most of the pediatric age group. So the answer for this will be do not give platelet transfusion. It is a consumptive coagulopathy. Dengue is a consumptive coagulopathy. It will use up the platelets very fast. So since the platelets get used up and they also exude through the capillary leak, we cannot give platelets and expect the platelet to rise. If there was bleeding, to block the bleeding, you may give platelets. But here, what have they written? There is no bleeding manifestation. So when there is no bleeding manifestation, there is no role for giving platelet transfusions. So the next step in this, the child will be A, wrong, no platelet transfusion. B, 10 ml per kg per hour ringalactate. That's a higher amount of fluid. If you overload, fluid will accumulate into the pericardial and peritoneal and pleural spaces, causing respiratory distress. So 10, 20 ml per kg, like option D, will be a wrong answer. This is a stable child. You just want to make sure that because of fever, he doesn't sweat and his BP doesn't fall because of dengue. So you're going to give minimum fluid, that is 7 ml per kg per hour of ringalactate. Okay. So the correct answer is C, 7 ml per kg per hour of ringalactate. Next question. A 10-year-old child presents with generalized edema. Urine analysis shows a 3 plus protein. 24-hour urine protein shows more than 3.5 gram per day. There's no hypertension, there's no hematuria. Serum albumin is low. Kidney biopsy showed segmental fibrosis and hyalinosis. The child also shows a poor response to steroids. Now, all this is kind of a very nice case setting of problem solving. Okay, let's go step by step and then look at the options. 10-year-old child, all the features suggestive of nephrotic syndrome. Very good. So all of you must have identified the first 3-4 sentences showed that there's nephrotic with no features of nephritic, no hypertension, no hematuria. So this is classical nephrotic syndrome. Now nephrotic syndrome has numerous causes. You have membranous, membranoproliferative, focal segmental glomerulosclerosis, minimal change disease. So there are numerous causes under nephrotic syndrome itself. Out of these, 95% of minimal change disease respond excellently to steroid. What has this child shown? Poor response to steroid. because of which they have done a kidney biopsy. Kidney biopsy does not show what minimal change should show. What does minimal change show? It shows flattening, attenuation of the podocytes, flattening of the podocytes, very small findings. Nothing big can be seen in the minimal change. That's why it's called minimal change. So that podocyte flattening is not what is seen here. This is showing segmental fibrosis and hyalinosis. So automatically option A, minimal change disease is ruled out. Now I will discuss option B. Option B is focal segmental glomerulosclerosis. Now look at the word focal segmental. Is there segmental even in the question? Yes. The kidney biopsy also has shown segmental fibrosis and hyalinosis. So yes, there is some segmental issues here. Kidney biopsy also has shown the disease also is focal segmental glomerulosclerosis. Sclerosis means fibrosis and hyalinosis. And focal segmental glomerulosclerosis does show poor response to steroid. So right now, before we analyze C and D, B looks like the best option. Now looking at option C. Option C is membranous glomerulopathy. Now membranous glomerulopathy will present with all the features of nephrotic with poor response to steroids, yes. But what does the biopsy show? Biopsy shows accumulation of the immune deposits forming in immunofluorescent cells a classical spike pattern. Now, when they say kidney biopsy shows immunofluorescent deposits which are seen under the immunofluorescent microscope with a classical spike pattern, then it is membranous glomerulopathy. This shows typical segmental fibrosic changes. So, this is not membranous glomerulopathy. IgA nephropathy. Now, IgA nephropathy is a totally different condition. IgA nephropathy is a synpharyngitic hematuria. So, in IgA nephropathy, whenever the child has an upper respiratory infection, at the same time, the upper respiratory tends to trigger the immune system to damage the glomerular basement membrane. So, RBCs trickle out. That is IgA nephropathy. So, pharyngitis. Along with pharyngitis, the child is having hematuria. This is not even a condition like that. Hence, IgA nephropathy is also the wrong answer. In fact, that's the DD for hematuria or nephritic syndrome. So here, obviously, the answer will become B, focal segmental glomerulosclerosis. Next question. A 10-year-old child presents with hyperglycemia and diagnosed with severe diabetic ketoacidosis. Bicarbonate was very low, 4. Normal bicarb, 22. pH of 7, again acidosis. RBS of 40 and potassium of 4.5. So what is the next management in this child? A, 10 ml per kg normal saline over 30 minutes, which means a 7% deficit correction followed by insulin infusion with potassium chloride of 20 millimole per liter and bicarbonate. B, 20 ml per kg NS. This is a little higher fluid. 10% deficit correction over 30 minutes, followed by insulin infusion. Just a minute. Ammu, can you please stay exactly that side here? It is good. And just don't make any noise because I'm recording. Okay, please. So let's look at the options here. So here the options are discussing the amount of fluid, the amount of time, and whether insulin has to be given with potassium and bicarbonate. So option A, 10 ml per kg normal saline. B, 20 ml per kg of normal saline. Followed by both you have given insulin infusion and potassium chloride and bicarbonate in option A. Option C, the fluid of choice is changed. The fluid of choice here is ringer lactate 10 ml per kg and 20 ml per kg ringer lactate with again insulin infusion and KCl with or without bicarbonate. Now, in diabetic ketoacidosis, in classical management, so the classical management is where you will give normal saline as the fluid of choice. Yes, many intensivists may disagree with me, and nowadays the fluid of choice is becoming ringer lactate. However, still in textbooks, as far as the undergraduate level goes, we are discussing normal saline as the fluid of choice. So you are going to give normal saline. So the first two options is that we are going to consider, where it is 10 ml per kg or 20 ml per kg. Now, in severe DKA, when the bicarb is 4 and the pH is so low, the best option is to give 20 ml per kg of, yes, 20 ml per kg of fluid, normal saline, followed by insulin infusion. Now, when we say followed by, it means essentially both are started at the same time. The 20 ml per kg normal saline goes in one cannula and the other line, the insulin infusion is started. The minute insulin infusion goes, what does insulin do? Insulin relocates potassium intracellularly. So all the intracellular potassium which has come out will suddenly be start moving intracellular and the serum potassium values will come down. Hence, what is our next option? We should add potassium to the IV fluid. So, along with 20 ml per kg fluid of normal saline, we need to give insulin infusion. Obviously, this is insulin deficiency, and we need to add potassium. So, sorry. So, we need to add potassium. So, all these three options are there in what? In option B. You're going to give a good amount of fluid. 10 ml per kg is not going to suffice. You're going to give 20 ml per kg. Fluid of choice is normal saline. You're going to give insulin infusion and you're going to give fluid with potassium chloride. Remember, in pediatrics, usually we do not put bicarbonate to correct acidosis easily. The cause of the acidosis is treated first. That is why I have removed the options where bicarbonate is there. Bicarbonate should be used very selectively as a drug. We cannot use bicarbonate as and when to just treat the acidosis. It's like treating paracetamol as an option for fever instead of treating the cause of fever. Like all of you understand that is wrong. Similarly, treating every acidosis with bicarbonate is only going to make the carbon dioxide retention and the dyspnea more. It is not going to treat the cause of acidosis. The cause of acidosis is the fact that there is no insulin and so the metabolism has become in a way that there's a lot of ketones are being produced. So that you have to treat with insulin infusion. That is why I have selected the option B as the correct answer, where the fluid is good amount, the choice of fluid is good, you're giving insulin infusion, you'll give fluid with potassium because the potassium will soon come down as the insulin goes in, the potassium will be located intracellularly. I have not selected bicarbonate because in pediatrics we don't use bicarbonate so regularly. In adults, yes, in very severe acidosis where the pH is really low, we use bicarbonate only in inborn metabolic errors where the child has severe lactic acidosis and there the bicarb is very low. Yes, as a life-saving measure, we do use. But in diabetic ketoacidosis, the minute you start insulin, child tends to recover. So I've selected option without bicarbonate. Fluid, always the larger amount, 20 ml per kg. Choice of fluid, normal saline. Now identify the correct match of milestone and corresponding normal age of attainment. This is a simple recall question. I think this is one of the simplest questions in the INI-CET exams. So I will not discuss the matching. Let's discuss this side. Option A, mature pincer graft. When is it attained? 12 months. What is attained at 9 months? Reverse. Immature pincer graft. That is why A is the wrong answer. B, making a tower of 2 blocks by 2 years. When does a child learn to stack blocks? Child learns to stack blocks as early as 1 year. So the fact the child is making a tower of 2 blocks at 2 years is wrong. This child will learn to make a tower of 2 blocks by 15 months itself. So tower of 2 blocks by 2 years is wrong answer. Bidextrous approaches, approaching an object with 2 hands. When does the child start reaching out? 4 months. So when is the bidextrous approach? Bidextrous approach is as early as that. Unidextrous approach, understanding that the object is to my left, so I should approach with my left hand. This object is to my right, I should approach with my right hand. This is unidextrous approach. This occurs a little later. So that is why bidextrous approach till 6 months is also the wrong answer. So bidextrous approach is usually at 4 months and by 6 months we have unidextrous approach. Now that is why C also becomes the wrong answer. D, transfers objects from one hand to another hand 6 months. This is absolutely correct. The child has approached it bidextrously and now is learning to transfer from one hand to the other by 6 months. So by 4 months he has held it. Then he has learned to leave it and hold like this from one hand to another. That is 6 months. So the correct answer is D, transfers objects from one hand to another, 6 months. Next question. Which of the following are major or minor criteria for acute rheumatic fever? Polyarthralgia, chorea, carditis, subcutaneous nodules, and decreased PRN. This is also a completely recall question. So this was modified Duckett-Jones criteria. So which are the major criteria? This you all should be able to tell me like the back of your hand. Because you're studying it for so long. Even in medicine, you all study. Polyarthralgia, yes. Chorea, yes. Carditis, yes. Even pancarditis is okay. D, subcutaneous nodules, yes. So all these are major criteria for rheumatic fevers. E is what? Decreased PR interval. What did we learn as a major or minor criteria? The minor criteria were prolonged PR interval. So decreased PR interval is not a minor criteria. It is prolonged PR interval which is the minor criteria. So the answer E is not in this scene. So now what? So option E is not in the minor criteria, and the answer which is the minor criteria is prolonged PR interval. Now, just for the sake of completion, you have 5 major criteria. Which major criteria is missing? The criteria which is missing is erythema marginatum. That is the missing criteria. And you also have minor criteria, presence of leukocytosis, presence of the essential criteria, all that other separate other criteria which are present. Okay, the presence of the throat swab, cultures, etc. Okay, so for this question, remember the 5 major criteria. Here they have put the decreased PR interval, which is a minor criteria. That should be prolonged PR interval. So which are the major criteria? A, B, C, D, 4. E is not the right answer. Which shows A, B, C, D? That is the answer 3, which was A, B, C, D. By my understanding, 1, 2, 3, 4, 5 would have been there, and the options should be 1, 2, 3, 4. But for ease of understanding, I have written it like this. So this is the Duckett-Jones criteria. A child presents with recurrent pneumonia and respiratory distress, but no cyanosis. A continuous murmur is heard below the left clavicle. What is the most probable diagnosis? Now, just by looking at this, there is no cyanosis. Why would they say no cyanosis? They will say no cyanosis in a respiratory case, only the child is very sick. No? So, no cyanosis with a murmur essentially means it's a cardiac condition, which is acyanotic congenital heart disease. Okay. Acyanotic congenital heart diseases do present with recurrent low respiratory infection. That is correct. So, this is the condition which is acyanotic congenital heart disease. So, there are 4 acyanotic congenital heart diseases. Which are they? ASD, VSD, PDA, coarctation of iron. All 4 have been given as options. Now, here is where you have to go further. Here, what have they discussed regarding the murmur? A continuous murmur is heard below the left clavicle. Now, let's discuss the options. A, ventricular septal defect. Now, what murmur do you hear in ventricular septal defect? You will hear a pansystolic murmur in what is called the Erb's area or the tricuspid area, just between the second and the fourth intercostal space, just lateral to the sternum. That is where you hear. That is called the Erb's area. You hear loud murmur there. That is the pansystolic murmur of ventricular septal. Here you are talking about continuous murmur, which means it's heard during systole and diastole. Continuous murmurs are also called systolo-diastolic murmurs. ASD. Now, ASD is a connection between 2 atria, left and right. Now, by nature, both atria do not operate at high pressures. They operate at much lower pressures. So, there is no great murmur that can be heard in ASD. Sometimes a soft systolic murmur can be heard. Usually, ASD is characterized by a wide fixed second heart sound. Okay, that is the classical feature of an ASD. Continuous murmur is never heard in ASD because there's no flow like that in diastole between these two low pressure chambers. So ASD is not the right answer. Third is coarctation of aorta. Now, coarctation of aorta, typically, the coarctation is below or ahead of the, this one, sorry, the coarctation occurs below or above the attachment of the ductus. So, postductal coarctation or preductal coarctations occur. Now, this preductal postductal only decides if symptoms are present on the left hand or symptoms are present in the upper limbs versus the poor flow symptoms of the obstructive features and the poor flow to the lower limbs. The murmur in coarctation of aorta can be heard as a continuous murmur over the back. This is primarily because of the collaterals. You cannot hear below the clavicle anything because the coarctation occurs well behind them. The heart, the coarctation occurs behind it. So in the back, the collateral will develop and that murmur can be heard. More commonly, you will have features of hypertension in the upper limbs and hypotension in the lower limbs. So, systolic murmurs are more common and some kind of murmurs which are heard over the back, not below the left lung. Option 4, patent ductus arteriosus. Patent ductus arteriosus is the connection between the left pulmonary artery and the aorta. Now here, this arch of aorta and the left pulmonary artery branch, this position is exactly below the left lung. And this high pressure, the aorta pumping at the systemic pressure and the pulmonary artery at the left side going at a very low pressure, there's a high pressure flow. And during systole or diastole, there is going to be continuous flow from the aorta into the left pulmonary artery, resulting in a continuous movement, which is exactly what our system is. Sorry, which is exactly what our question is. Our question said there's a continuous movement beneath the left lung. So the correct answer is patent ductus arteriosus. Answer D, patent ductus arteriosus. Next question. This is also a completely recall question. Which is not used in status epilepticus? A, valproate, B, ethosuximide, C, fosphenytoin, D, levetiracetam. Now, if you all have looked up the classes, you will find there's a beautiful flow chart for status epilepticus. Okay, in that flow chart, all the drugs are seen. You first have fosphenytoin. Sorry, you first have nowadays levetiracetam. After levetiracetam, you can have valproate, fosphenytoin, phenobarbital, and later on it goes into midazolam infusion and thiopental coma. There is no role for ethosuximide there. Ethosuximide is a very, very selective agent and is used only in one type of seizure, which also I'm sure you can recollect so that you will learn two things here. Ethosuximide is a drug of choice in dash, drug of choice in absence seizures. So, and it is a drug of choice usually in older children. In smaller children, carbamazepine and valproate all work very well, but in older children, we do use ethosuximide. It is a long-acting agent and a slow in onset agent. It has to be graduated and hiked up. You cannot suddenly start it. So slowly you increment the dose and reach full dose. That is not possible in status epilepticus. Hence, the correct answer, which drug is not used in status epilepticus? That answer is B. Ethosuximide is used in absence seizures and not in status epilepticus. Next question. Which of the following is true about Gaucher's disease? Now, Gaucher's disease occurs because of deficiency of dash. All of you will be able to fill the answer. The answer is glucose cerebrosidase. So option A is correct. Or the first option is correct. Second option, the cells have crumpled tissue paper appearance of cytoplasm, which is also correct. In Gaucher's disease, you have the wrinkled tissue paper appearance. So that is correct. So option number 2 is also correct. Option 3, foam cells. Foam cells are essentially what cells? They are cells where there's a lot of intracellular metabolite. That accumulated metabolite makes the cell looks full with some kind of foamy substance. In Gaucher's disease, there is accumulation of metabolites because of deficiency of glucose cerebrosidase. So these foam cells are going to appear in most of the storage disease. They can also be seen in Niemann-Pick. They can be seen in so many conditions. But they are also seen in Gaucher's disease because this is also a storage disease. So option 1, option 2 and option 3 are correct. Option 4, It completely contradicts option 1. Option 4 says it occurs due to deficiency of ceramidase. Now, ceramidase is a totally different enzyme. It is seen in a condition called Farber's disease. It is not seen in Gaucher's disease at all. So, option 4 is wrong, whereas the first three are correct. So, this is the storage disease and having glucocerebrosidase deficiency. Wrinkled tissue paper appearance in the cytoplasm. Foam cells can also be seen. So 1, 2, 3 are correct. The option is D. So with that, we'll be coming to the end of our 15 questions in the pediatric section of the INI-CET. I hope you all take this as a very good learning session and study hard, work hard, and success will beam upon you. Wishing you all the very best. Thank you.